Some of you have been to the booth out there. New kid on the block. We've been waiting 20 years for this drug. Buy stock. This is a drug that has the potential to alter vasomotor symptom FACE. It's already been used in other countries for many years. Just got approved for Great Britain in January, and they are the hardest to get things through. Neurokinin receptor antagonist, fenzolinetant. I had to ask him how to say that. Because this drug works in the neurological system. Remember what causes hot flashes? Alteration in neurological system related to hypothalamus. That's where this works. So it works by actually preventing that regulatory problem from happening. Non-hormonal in terms of no estrogen. So okay for your patients who can't take estrogen, and that's a big deal. For those patients up until this point, there's been very little relief. So we have a new kid on the block here. There's some issues. Obviously, every time you start a new drug, you're going to have some post-marketing issues. We know liver transaminase elevation is a problem, so we want to test before, make sure liver enzymes are fine. And this is the one class of drugs that is recommended for testing liver enzymes at 3 months, 6 months, 9 months, and a year. Okay, which tells me something. If the manufacturer is recommending this, it tells me that this could be a significant problem. It hasn't been on the market long enough to really know that, but this is kind of like the new up-and-coming help for people with vasomotor symptoms. I'm anxious to see how this takes off. I think it's going to take off very, very nicely. Complementary or alternative medications. Here's the problem. Everything we've talked about before, from SSRIs to here, are FDA-approved drugs. You know that over-the-counter products are not FDA approved. That's a problem. They're not FDA regulated like the other drugs are that have to go through clinical trials, preclinical trials, final approvals. These drugs are just out there on the shelves. The problem with that is we don't know enough about any of these drugs. So they are available over the counter. Black cohosh, the first one, has some very significant decline in vasomotor symptoms over time. So yes, it is effective. However, it is also not without very serious potential side effects, like liver damage. So what do we do here in the United States? We have a little bit of a habit here. So if one pill works well, 2 would work better, right? Yeah, that makes sense to me. And if 2 works better, I should probably take 3. 3 works. I might think about 4. I'm not sure I would do it, but I might think about 4 because that's the way we do things, especially in the over-the-counter world. I do a whole lecture on over-the-counter, and it is totally amazing the number of patients in research that say, oh yeah, I routinely take 2 to 3 times the amount on the bottle. The problem with black cohosh is that can definitely result in liver damage. And so that is a big deal. If your patient tells you they're on this, then you need to be absolutely certain they're following the dosing guidelines. American Menopause Society does not recommend this product for vasomotor symptom management because there simply is not enough research to satisfy us that it is not a harmful medication. Evening primrose oil, on the other hand, is actually relatively safe. The only issue, there's 2 issues with it. The one is potential for bleeding. So if a person already has bleeding potential, maybe they're on Coumadin, something like that, this would not be for them. And the second thing is the potential in patients who are schizophrenic to cause exacerbation of symptoms. So if neither of those 2 are an issue, it's a fairly safe drug. Side effects are usually GI in nature. Patients might feel a little nauseous, might get some diarrhea from it, maybe a little skin rash. But the efficacy is very questionable. Okay, but low risk potential, fairly low risk potential, right? So why don't we say to patients, you want to try that? Go ahead, give it a shot. Make sure you follow good guidelines. Make sure the dosing is appropriate. Make sure that it's purchased from a reliable source. Okay, low risk, potential for relief, physically, psychologically, better potential. So traditional medicine. Hormone intervention has been around a long time. Those of you who've been in practice for a little while, the last bullet point there might remember the Women's Health Initiative. Women's Health Initiative was, I'm going to go back in the 90s. I think it was in the 90s. And what it strove to do is to determine the risk of hormone replacement therapy, especially cardiovascular risk. So they started the trial and they ended it early. They ended it early because they found so much risk, scared women senseless. I was working in an OBGYN practice at the time doing family medicine, and the phone was ringing off the hook when that morning news came out. I want to stop my hormones. I want to stop my hormones. Unfortunately, what was discovered over time is the study itself had serious flaws. They only studied combination products of estrogen, progesterone. And so really, could we say what was causing the sudden increase in cardiovascular events? No, we couldn't. And so what happened with the Women's Initiative is it put a lot of thought into women's heads, and they are, don't take it. You will get a heart attack, you will get a stroke, you will get breast cancer. Not you might, not it's a risk, you will. Again, I moderate some women's boards, and this is still in women's minds. But we've come a long way, and we know a little bit more now. And interestingly, our governing bodies are now recognizing this as a valuable means of controlling vasomotor symptoms. American Menopause Society, for example, was for many years dead set against hormone replacement therapy, but their new guidelines do say, yep, okay, go for it. Estrogen done appropriately is a good idea. So FDA approved and can reduce vasomotor symptoms up to 75% compared to placebo. Not just reduces, but compared to placebo. That's a pretty big number. Currently, it is the most efficacious management of vasomotor symptoms. Not for everybody, we're going to talk about that. And as an oral form, it comes in several forms. It comes as a conjugated equine estrogen. You hear about this a lot. The brand name is Premarin. You're going to hear a lot about Premarin. One of the ways Premarin is manufactured is by the collection, or the way it is by the collection of horse urine from pregnant mares. And so PETA's all over that. And so there's all sorts of ethical issues with that. But it is a horse source. The next one, synthetic estrogen, made in the lab. And then estradiol, which we get estradiol, we can get compounding, we've got many ways. We're going to talk about that on a different slide. We also have plant-based estrogens. Again, we'll talk about that in a minute. Oh, I missed something. I am so sorry. I have to go back for a second. Can we readjust for a moment? I missed soy isoflavins, which is kind of like important to the next discussion. So, soy, we talked about soy as a non-pharmacological, non-hormone intervention. But is soy really a non-hormone? It is a plant-based estrogen, and in the body, it can have one of two effects. It can have an estrogen effect. Guess what? It can have an anti-estrogen effect. And some of the research that's shown that increased intake of soy products results in decreased breast cancer risk, which would be contrary to what you were thinking, right? If soy has some estrogenic effect, wouldn't it increase breast cancer? The research actually shows it can decrease. Now, our friends in Eastern Asian countries naturally eat a great deal of soy. And they have lower levels of breast cancer. And guess what? They have lower levels of vasomotor symptoms. Okay? But again, not without side effects. Problems. No FDA approval, over the counter, no regulation, no standardization of doses. So that's a big problem. If you're doing pharmacological as opposed to eating soy products. So that's a problem. And then, of course, we don't know what effect it is going to exert in your body or my body. Is it going to exert estrogenic or non-estrogenic? We don't really know. Okay, so that's the problem with soy. So the recommendation is that if the patient's going to do soy isoflavin, they should do it dietarily. Increase tofu, lentils, mostly soy increase, dietarily, not supplementation. I'm so sorry about missing that. Okay, so we also have plant-based estrogen, which is mostly from soy formations. We'll talk about that on a different slide. Now, topical is always estradiol. So topical, we put it on the skin, we put it intravaginally, is always estradiol. Very nicely absorbed into the tissues and can manage a lot of things. Like, for example, let's use a real life clinical example. Your patient comes in, your patient has been menopausal for, let's go with as much as 15 years. Maybe she's 69, maybe she's 70, and she's been menopausal for a long time. She recently had issues of incontinence, urgency, and frequency. No UTI, physical exam is within normal limits. For that patient, she has been off all hormones, her own natural hormones, for a very, very long time. The recommendation is we don't really want to start her on an oral, we definitely want to start her on an oral or a patch. We can do direct application vaginally and to the urethra. Just take a little dab of estradiol cream to the urethral every day. I promise you, her symptoms will be greatly, greatly improved. So that's the way to treat the patient without going through systemic absorption. Always lowest dose, shortest time, considering individual risk. We're going to go through individual risk on a different slide. But the point of this is, you might be a candidate, you might not. You might be a candidate, you might not. And that only comes through assessing the person's individual risk. History of breast cancer, that's a problem. Do they have a uterus? Do they not have a uterus? So, have they had thrombolytic events? Risk benefit, and we're going to talk about exactly what they are. Lowest dose, shortest time. We always say start low, go slow. So whatever dose you're going to be giving the patient, you're going to start at the lowest level and increase until her symptoms go away and stay.